Well, hello. Welcome to another session of Digital Surgical Pathology Slide Review and Sign Out. I'm Dr. Louis Hassel, and we're pleased to bring you these slides courtesy of the Digital Anatomic Pathology Academy, which is a joint venture of the Digital Pathology Association and Path Presenter. My time, of course, is provided by the University of Oklahoma Health Sciences Center, and here our Stevenson Cancer Center and NIH designated Cancer Center. Our case today comes from one of the very challenging and interesting cases presented recently, that of a 42-year-old, excuse me, that typo there, a 42-year-old woman who presented with abdominal pain and adnexal mass and what appeared to be potentially disseminated tumor. On exploration, she was found to have rather socked in tissues, and so only fragments and biopsies were obtainable at the time of laparoscopic exploration. Of course, due to the advanced stage, consideration of resection was not feasible for her. As you can see from this low power image, our tumor has areas of very blue staining tissue with as well as intervening areas with apparent necrosis. We can see a little bit of what's likely residual ovarian parenchyma here with a follicle-like structure here, as you can see. And then within the tissues itself, this small dark blue cell neoplasm with areas of necrosis. Notice here that we do have some intervening fibrosis as well around the tumor, some desmoplasia, and we can see that these tumor cells on higher magnification here have very scant cytoplasm, fairly uniform round nuclei, a lot of mitotic activity. We'll look at some other areas here as well, such as this area here. And you can see there's even a bit of a starry sky type of pattern with these areas where we have cell dropout and pycnotic central nuclei surrounded by clear spaces. Here you can see the chromatin is rather granular, a little bit of central nucleoli noted here. And we can see also very frequent mitotic figures along with the activity of necrosis, tumoral type necrosis going on in the background. Of note, things that we do not see here are other identifiable structures, carcinomatous structures. We don't see any cystic changes, any follicle-like structures. We don't see a diffuse pattern of growth, so we see sort of chorded and trabecular pattern growth, with broad zones of necrosis far outweighing the areas of viable tumor. We'll look here again at some other areas in here just to further expand our visual memory of this case lesion. A few cleared out spaces around the cells, but generally very high grade appearing neoplasm and a lot of necrosis. So let's talk about small cell neoplasms in the ovary and think first in this case, what does the differential diagnosis include? Well, there's a number of primary tumors that can occur in the ovary, which include small cell carcinoma of the hypercalcemic type. And checking the chart on our patient, the patient did not have hypercalcemia. However, not all patients with small cell carcinoma of the hypercalcemic type have hypercalcemia. So it's generally present, but not always. There is an additional type of small cell carcinoma designated the pulmonary type that can occur in conjunction with oftentimes other epithelial tumors like endometrioid carcinomas as well. We have undifferentiated carcinoma, just no differentiating features. The adult type granulosa cell tumors can have a small cell appearance, although usually are not associated with extensive necrosis or with the high mitotic rates that we've observed here. Sertoli Leydig cell tumors, particularly the more poorly differentiated ones, can have a small cell appearance, but should have some recognizable tubular component to allow us to classify them as a sex cord stromal tumor. Endometrial stromal sarcomas, the high-grade types particularly, can have very small cells, but will grow in cohesive groupings and have the delicate vasculature that we associated with stromal sarcoma. High-grade endometrial stromal sarcomas may be less well differentiated and less well recognized, and so could have necrosis and some features we see here, but not the sort that we've seen. Melanoma, primitive neuroectodermal tumor or Ewing's tumor could fit into that category as well. And of course, the rhabdomyosarcoma group of embryonal or alveolar type can have small cells. So those are the primary tumors that we might see. Then, of course, there are the things that can travel to the ovary. Lymphomas, leukemia doesn't look like that in this case. Small cell carcinoma of the pulmonary type that's metastatic from elsewhere. Metastatic melanoma, desmoplastic small round cell tumor, a primary intraperitoneal disease, especially endometrial stromal sarcoma, rhabdomyosarcoma from another site, Ewing's or neuroblastoma can, of course, travel in this situation. And with, as is important to note in this situation, that clinical history and evaluation of the entire patient, their history and their presentation is probably the most valuable special stain in identifying and excluding these patients. So your radiographic studies may help a great deal, but the history can be vital as well. So needless to say, in the modern era, a panel of immunohistochemical stains was performed on this case, and this summarizes nicely the results. We had positive staining with cytokeratin 7, EMA, and synaptophysin. However, other neuroendocrine markers like CD56 were negative. Hormone receptors were negative. Sex cord stromal marker, inhibin, was negative. Other epithelial markers like P63, PAX8, S100, TTF1 were interpreted as negative. Now, of note, a couple of things were not done here that might have helped us a little bit further. WT1 was not performed, nor was any mutational analysis performed to look for SMARCA4 mutations that might be commonly expected to be present in small cell carcinoma of the hypercalcemic type. So based on the immunohistochemical results, we can exclude undifferentiated carcinoma. We've got some neuroendocrine markers. We can exclude adult granulosa cell tumor, Sertoli Leydig tumor, endometrial stromal sarcoma, melanoma, primitive neuroectodermal tumor, and alveolar rhabdomyosarcoma, based on the cytokeratin results and the neuroendocrine results that we have that are staining positive, as well as the negative stains. So then we're left with these two primary small cell carcinoma differential considerations. Is this of the pulmonary type? Is it of the hypercalcemic type? Or is this just a neuroendocrine carcinoma that has overgrown other elements? And quite frankly, we don't have the full studies to differentiate that. As I mentioned, it is important to note that the small cell carcinoma of the hypercalcemic type may not actually be a carcinoma, but may rather be a germline-derived tumor that has essentially overgrown. That it's positive with some epithelial markers does not necessarily mandate that it's carcinoma, especially given some of the genetic data that's emerging. The neuroendocrine features might be seen in the pulmonary type, but small cell carcinomas of hypercalcemic type can, in some instances, also have synaptophysin positivity. Usually expression of EMA, CK7, and WT1 would be fairly specific for this marker, and that was not done. So as is unfortunately the case too often, sometimes we're left with a little bit of ambiguity, and especially reviewing a case retrospectively. Our diagnosis is small cell carcinoma of the ovary with neuroendocrine features. favor pulmonary type, perhaps can't totally exclude small cell carcinoma of the hypercalcemic type in this situation. So that brings our case somewhat more into focus. Thanks for joining me in this discussion. There's still a lot to learn in cases like this, and since this is a rare entity, there's still many more things to be studied and gleaned from this before we have good results. Of note, the small cell carcinomas with hypercalcemia are usually younger patients, usually under age 40, or patient just over age 40. And so this would be a very uncommon diagnosis in an elderly woman, which would be more likely of the pulmonary type or metastatic. So hope you'll join me again sometime. Please subscribe so you don't miss upcoming videos, and share this with friends and colleagues as you see fit. Thanks very much.